Lawrence and Dr. Glavitsky for helping us get this underway. Dr. DeMuzio and I are both excited to have everybody join us again for the May version of the JVS Journal Club. This month, it's being hosted by the University of Washington and also by the University of Southern California. We have our presenters from the University of Washington, Dr. Matthew Smith, who is a clinical assistant professor of surgery, and also one of his residents, Kirsten Concha-Moore, who is a second-year resident. And then from the University of Southern California, Dr. Gregory McGee, who is an assistant professor of surgery, is being joined by his second-year fellow, Dr. Callie Johnson. Our author guests, which we're excited to have for the paper, Endovascular Interventions for Claudication Do Not Meet Minimum Standards from the SVS Efficacy Guidelines, Dr. Jonathan Bath, who is the first author, along with Dr. Karen Wu, who is the senior author. And again, Dr. Schimmelhorn is on this paper and he's joining us too. From the validation of global limb anatomic staging system in the first time lower extremity revascularization paper, Patrick Liang and Dr. Schimmelhorn are joining us. We're also very excited to have our two special guests discussing the papers, Dr. Matthew Doherty, who is a professor of surgery at the University of Pennsylvania, and then Gail Tang, who is an associate professor of surgery at the VA Puget Sound and the University of Washington. Just a couple of small housekeeping things. We do ask that you stay muted while the presentations are going on. You can put your questions in the chat. Dr. Tang and Dr. Doherty will go through the questions and talk with the authors as well as the presenters to ask those and answer those. And then, of course, the event is being recorded for those that cannot make it in person. And finally, the next JVS Journal Club is going to be on June 9th. It's at 7 p.m. Eastern. It's going to be hosted by the University of Alabama, Birmingham, and also SUNY Upstate Medical University. So with that, I will stop sharing my screen and we will move into the first paper on endovascular interventions for claudication do not meet minimal standards for the SVS efficacy guidelines.
All right. Thank you very much, Dr. Humphreys and Dr. DeMuzio and Dr. Lawrence and Dr. Glavitsky and the Journal for Vascular Surgery for allowing us to participate in this. We're going to present a paper entitled Endovascular Interventions for Claudication Do Not Meet Minimum Standards for the Society for Vascular Surgery Efficacy Guidelines. Now, I chose this picture because it's mostly West Coast presenting this time around, but also I thought it rather interesting as I looked for a picture to highlight claudication, and you search claudication, you get a number of pictures that look like this, often from the websites of practice groups around the country, often in OBLs and other types of things, but it kind of gets to the nature of what are we doing here and are we treating these patients right? So just to review, try to make this relatively brief, but the Society for Vascular Surgery practice guidelines that were put forth by Dr. Conti and colleagues back in 2015 are part of the principles behind this paper. And they looked at this time at the management of asymptomatic disease and claudication. And I just wanted to highlight a couple of these specific recommendations. So they first said that we suggest that a minimal effectiveness threshold for invasive therapy in treatment of intermittent claudication be a 50% likelihood of sustained clinical improvement for at least 2 years. Now, these numbers weren't just made up arbitrarily. They were based on some good data, largely for bypass and open surgery, but also some endovascular procedures as well, or some endovascular studies as well, to kind of set this as a threshold for what we should be aiming for these patients. Now, of their grade 1 level A evidence guidelines that they set forth in this, they recommended that patients undergo a multidisciplinary comprehensive smoking cessation interventions and that this occur until the patient was free of tobacco completely. Then they also recommended that all patients with intermittent claudication be started on statin therapy as a grade 1 level A recommendation, in addition to all patients being started on antiplatelet therapy, either aspirin primarily or Plavix if patients couldn't tolerate aspirin for any reason. And then finally, they recommended that the first line therapy for these patients after they were medically optimized was that they undergo supervised exercise program consisting of walking a minimum of 3 times per week for 30 to 60 minutes for at least 12 weeks in all patients that were able to. And only after this point, if patients had this complete medical optimization, should we consider really treating intermittent claudication procedurally. Now, they also made some recommendations for how we should be treating them procedurally, which we won't dive into the weeds on that, but their primary recommendations for both aortoiliac disease and short segment femoral popliteal disease were the use of endovascular procedures. Obviously, if it's a longer lesion, they were recommending bypass with saphenous vein as a primary conduit. Now, with all these recommendations and kind of the increasing incidence and prevalence of claudication in our vascular patients around the country as our population ages, and the both clinician and patient perceived minimally invasive nature of endovascular procedures, there's been a large uptick in treatment of claudication with primarily endovascular procedures. And that's prompted a number of studies lately that have brought some potentially negative attention to this also. Dr. Hicks published back in January about the overuse of early peripheral vascular interventions in claudication. And then Dr. Meltzer and colleagues put out a paper highlighting the practice patterns of vascular surgery's 1%. Now, neither of these were specifically targeting endovascular procedures in claudication, but they did focus around claudication. And one of the overlying themes of both of these publications was that we may be intervening on people too often, too much, and inappropriately. So that partly brings us down to the beauty of the Vascular Quality Initiative is that we can take our real world data and kind of look as a global QI project and find out whether or not we're treating these patients appropriately, and more importantly, where we can make improvements and how to make sure that we are treating them appropriately. So that brings us to today's paper by Dr. Bath and Dr. Lawrence and colleagues. Endovascular interventions for claudication do not meet minimum standards for the Society of Vascular Surgery's efficacy guidelines. And with that, I'll hand it over to Kirsten Concha-Moore, one of our esteemed second-year residents.
Hi there. My name is Kirsten Concha-Moore. I'm a second-year vascular surgery resident at the University of Washington. And I just want to say thank you so much to Dr. Demuzio and Dr. Humphreys for this opportunity, and the JVS for creating this online journal club. Just to get started here. Like Dr. Smith has said, we're discussing today's paper, the endovascular interventions for claudication do not meet minimum standards for the Society of Vascular Surgery efficacy guidelines. Just a little background about peripheral arterial disease. It affects about 8 to 12 million patients in the US, and most common symptom is often claudication, so intermittent claudication is what we're discussing today. According to the SVS, intermittent claudication is defined as reproducible discomfort in a specific muscle group that is induced by exercise and then relieved by rest. And current data suggests that management of intermittent claudication should be individualized. And like Dr. Smith was mentioning, risk factor modification prior to invasive treatment should be focused on specifically smoking cessation, medical therapy and optimization, and the supervised exercise program. These two papers, Norgan et al. And Cannell et al. Were mentioned in the paper and mentioned that intermittent claudication will progress to rest pain, tissue loss, and amputation in less than 5% of the patients. Other studies suggest, such as the Stigvant et al., which is a within the European Journal of Endovascular Surgery. It was a meta-analysis reporting of the mortality and disease progression in PAD, suggesting that intermittent claudication in patients have a risk of progression anywhere from 12 to 29% over 5 years. And like Dr. Smith was saying, the SVS practice guidelines for atherosclerotic occlusive disease of the lower extremities management of asymptomatic disease and claudication recommend that treatment of intermittent claudication should provide at least greater than 50% likelihood of clinical efficacy over or greater than or equal to 2 years. So the purpose of this study, the objective of the study was to examine the outcomes of endovascular management of intermittent claudication reported in the VQI and compare them with the Society of Vascular Surgery guidelines for intermittent claudication treatment to determine whether real-world results are within our guidelines. In terms of the methods, the VQI was retrospectively queried. The patients who had undergone endovascular interventions for the indication of intermittent claudication between 2004 and 2017 additionally have to have at least one required follow-up entry between 9 and 12 months following the procedure. The patient cohort variables included the criteria for patients with complete data and follow-up for at least greater than 9 months, and patients were excluded who had undergone emergent procedures and intervention for another indication other than intermittent claudication, and those who had incomplete data. The primary outcomes for the study were 1, intermittent claudication recurrence in the ipsilateral limb, as a yes or no, and then the performance of repeat procedures on the ipsilateral limb during follow-up. Statistical analysis was performed. Cox proportional hazard models were used to examine the factors independently associated with the time to intermittent claudication recurrence, repeat procedures, and account for the differences in follow-up periods among the patients. Kaplan-Meier survival curves were used to assess the freedom from intermittent claudication recurrence and time to repeat procedures. And additionally, a sensitivity analysis was done that looked at centers that were reporting follow-up data with greater than 9 months for the patients and for greater than 70% of their patients that were treated. In terms of the demographics for the study, 54,849 patients were identified that had an index limb first endovascular intervention for intermittent claudication. 29,068 of those patients were excluded as they were intervened on for other reasons, such as aneurysm repair, prior bypass, endarterectomy, other peripheral vascular interventions, prior open or endovascular inflow treatments, or prior endovascular infrainguinal treatments. Of those patients that met inclusion, that was 25,781. However, 16,152 patients met the inclusion criteria and met the at least one long-term follow-up data point between 9 and 21 months. Of note, just 79% of those patients had follow-up data entered at 18 months. In terms of the patients that were included in the study, the mean age of the patients was 66 years of age. The majority of them are male, the majority of them are white. Comorbidities included active smoking at the time of intervention was 45%, 84% had hypertension, 37% had diabetes. 60.4% of patients were noted in the study to be taking antiplatelet agents and statin, and 28% were noted at discharge, were discharged without antiplatelet or statin use. The disease progression for these patients was 6.2 for tissue loss and 2.7 for rest pain. And then the treatment modalities, if you look to the supplementary table on the right, there were individual treatments of angioplasty only, stent only, atherectomy only, or in combination. The majority of the patients had angioplasty and stent performed at 52.8%. Of note, balloon angioplasty alone was performed 16.7% of the time, and atherectomy alone or in combination was performed in 12% of the patients. If you look to the right, the Kaplan-Meier curve is demonstrating breakdown of the patients in terms of anatomic location that was treated. And the x-axis is freedom from intermittent claudication recurrence in terms of days. Of note, 32% of the patients were free from recurrent symptoms at 2 years. And then if we break that down a little bit further, at the 2-year mark, 43% of the patients who were treated with isolated aortoiliac interventions, 37% of those patients were still noting freedom from recurrence at the 2-year mark. Similarly, 8.7% of patients treated with aortoiliac and femoral popliteal interventions, 22% of those patients were free from recurrence at the 2-year mark. And 41% of patients were treated with a femoral popliteal intervention, and 30% were noted to have freedom from recurrence, as well as 43% of patients were treated with femoral popliteal and tibial interventions, and 20 of those patients were noted to be free from recurrence at 2 years. This is a similar curve, but looking at the freedom from repeat procedures. So 76% of patients treated with endovascular procedures for intermittent claudication were free from repeat procedure at 2 years. And then when you break that curve down, again, looking at anatomic distribution of where of treatment level, at the 2-year follow-up mark, 43.7% of patients were treated with isolated aortoiliac intervention. 86% of those patients were free from repeat procedure at 2 years. 8.5% of patients treated with aortoiliac and femoral popliteal intervention were noted that 71% of those patients were free from repeat procedure at 2 years. And then 42.3% of patients were treated with isolated femoral popliteal interventions, and 67% of patients were free at 2 years. And then 4.3% of patients were treated with femoral popliteal and tibial interventions, and 50% noted freedom from repeat procedure at the 2-year mark. In looking at the data further, adjusted analysis was done for claudication recurrence. And in kind of looking at these tables here, treatment for more than 2 arteries or use of atherectomy were both associated with decreased time to intermittent claudication recurrence. And of note, the use of antiplatelet agents and statin on discharge, as well as stenting, were both associated with increased time to intermittent claudication recurrence. Similarly, we have similar outcomes for the adjusted analysis for repeat procedures. Again, if more than 2 arteries were treated or atherectomy was used, that was associated with a decreased time to repeat procedure. And then the prescription of antiplatelet and statin at discharge was associated with increased time to repeat procedure. And lastly, stenting during index procedure increased the time to repeat procedure. So in discussion, kind of the summary, some points that I took from this paper, 68% of the patients were reported to have ipsilateral recurrent intermittent claudication within 2 years of treatment. Statin and antiplatelet use pre and post procedure increased time to intermittent claudication recurrence and time to reintervention. Of note, 28% of patients undergoing peripheral vascular interventions for IC were not prescribed antiplatelet or statin at discharge. The level of disease treated, the number of arteries treated, and use of atherectomy were associated with decreased time to recurrence and reintervention. And then 45% of patients were active smoker at the time of peripheral vascular intervention, despite the SBS guidelines grade 1A recommendations of smoking cessation for patients with intermittent claudication. Now, there's some limitations to this study. As many of us know, the VQI data is self-reported, and so it's subject to reporting bias. The VQI also lacks specific data regarding the severity of the calcification, the length and degree of stenosis or occlusion, or really details about the vessel features themselves. Also, intermittent claudication is based off of lifestyle limitation and is not necessarily objectively scored. So there's no validated measures for intermittent claudication symptoms or kind of quality of life reporting. And then also the lack of follow-up data could have skewed the data presented in the paper towards patients with poor outcomes. In future directions and kind of conclusions I got from this paper, I think according to this study, we are not meeting the SVS guidelines for medical management with antiplatelet therapy and statin or smoking cessation prior to intervention. Something I thought was interesting is it'd be interesting for further studies to evaluate the outcomes for patients that were treated according to the SVS guidelines, also undergoing endovascular or open interventions for intermittent claudication. Thank you so much.
So monitoring the chat, I'm going to ask Dr. Hingorani to go ahead and pose his question about the tibial interventions.
On the table too, in the figure, it looked like there was some mention of isolated tibial angioplasty. Do people do that for intermittent claudication? I haven't really been doing that.
Yeah, if we could have our invited author guest address the majority of the questions that came up in the chat, I think are more directed toward the authors.
No problem. Yeah, I'll be happy to fill that one. So yes, in the database there are some isolated tibial interventions performed for claudication. It was a very small number, as one would expect, and you know, I'm glad to see that. We didn't include it in the analysis because we didn't have robust data at 2 years. It didn't really meet, the standard error became very high, greater than 10% very quickly. But you have to wonder, you know, are people doing these things, or is it perhaps some poor report? So not poor reporting, but perhaps it's some misclassification of these things. But certainly we had enough data that we sort of looked at the whole bunch, and there were some who were having femoropopliteal and tibial treatments, and we included those. But we excluded the tibial ones. They just weren't enough to really make power. So, but yes, surprising.
Dr. Glowicki, would you mind addressing your question?
Well, I think we heard that there was no objective assessment of claudication. And also we heard the main conclusion that medical treatment is inadequate. Maybe the title should have focused on the medical treatment and not the poor results after the endovascular intervention.
Yeah, I think Dr. Lawrence and myself a little bit of a fan of stirring the pot a little bit, and perhaps with the title sort of being a little bit controversial. I mean, you know, it prompts a discussion. I think if we had said medical therapy should be more utilized, perhaps it wouldn't have caught the eye as much as we're not meeting the criteria. However, that being said, I mean, you know, clearly we are failing in some portions of it, Dr. Glowicki, I think. And so, yes, I think there's a lot of evidence out there. The CLEVER study, I was just looking up a couple today, the ironic study I've never heard of, a Swedish trial that looked at this sort of idea of best medical therapy versus intervention for claudication. And I think it just, everybody feels like we should be doing a better job. And I think the VQI data sort of supports that.
Could you actually clarify a little bit, because what was presented is that 79% of patients had follow-up data out to 18 months. But if you look at the numbers at risk in figure 2, you know, 694 in the aortoiliac group out of 5,595 patients is not anywhere close to, you know, that's 12% of patients, not 79% of patients. So it doesn't seem like what is presented in the life tables in terms of number at risk at all matches with the long-term follow-up data that was supposedly there.
Yeah, I mean, the long-term follow-up data is messy. This was a median long-term follow-up that we decided to put in as a blanket statement. We didn't, if you look at the tables, we included only that which we were confident really made it to a standard error of 10%, or sorry, less than 10%, I'm sorry. So, I mean, overall, if you split them up by groups, they all meet that level at different times. So they do all have different follow-ups. We're looking at 5 different groups, unfortunately. So lump them all together and we have some 18-month data, but you're right, it's not robust. That was sort of a more of a blanket statement. It doesn't, when you break it down into the groups, we probably have close to 9-month or 12-month data we can be really accurate with.
But that's kind of a problem because where your curves start falling off is at 365 days. And when you're looking at meeting a criteria at 2 years, and you say you really have solid data up to 9 months, isn't that a little concerning?
Oh, I don't think so. I mean, from the point of view of a paper, even at 1 year, the data clearly show that we're not even meeting efficacy. I think if one were to extrapolate, which obviously you don't tend to want to do, one would say that at 2 years, that these data are even poorer. Now, again, we had some 5-year data, we had some 3-year data. We decided that the best thing to do and the cleanest thing to do was really focus on, as I say, 365 days. I don't have it in front of me, but I've got my paper. But as I say, we were quite careful to make sure that we only included things that we felt that, again, had a standard error that we felt confident behind, that we could sort of stand behind. Some of the supplemental tables also somewhat helpful. I printed mine out, but they're very small. So I think that the take home is, yes, using VQI data to make some very hard conclusions about things is tricky. Dr. Maribi's point about having calcification data and anatomic data and such is well taken. It just wasn't robust when we looked at it. We couldn't say exactly what type of atherectomy, how long the lesions were. People just didn't really fill in that data well. So I think this paper is designed really to kind of give folks a flavor of what's been done in the real world and say that I think there's opportunities for improvement. So,
Dr. Smith, do you want to pose your question on the appropriately medically managed group?
Yeah, I do. Thanks. And John, I mean, I'm sure the data breaks down as you get into subgroup analysis, et cetera. But I think one of the biggest questions is what are the results in patients that were treated appropriately? You know, patients that were on aspirin, a statin, had stopped smoking, and who, didn't get a POBA for a calcified lesion. You know, as you mentioned, stents do better than no stents, so on and so forth. Do you have any data in that sense?
It's a great question, and I was just texting Dr. Wu and sort of seeing if we had looked at this at any stage, because we ran a few analyses. I don't believe we did, and honestly speaking, that would be one thing I would think about doing again if we were to restructure this. And we ran multiple iterations of this by folks, and it just sort of, it never came up. But it's a great point. It really is. It's probably a limitation of our analysis.
So a point that Dr. Sampson raises is that the study population 2004 to 2017, and there are a lot of changes in technology and medications over that time. For instance, and the other issue is, for instance, you don't have drug-coated balloons. Presumably they were just lumped in under plain old balloon angioplasty. Don't you think this would affect outcomes?
Yeah, absolutely. I mean, if you want to garner a large amount of patients in order to get a good N when you're breaking things down, you have to accept the fact that practice patterns change over time. What we're doing today is not the same as what we were doing back then. There were some codes that obviously were retired previously. There were some codes that are added. There's a new whole section for COVID now, if you look in the data dictionary. And so, it's just one of those things. If we restricted this to, let's say, 2015 through 17, we're just not going to get the level of data. And so I think you have to understand that I think we all feel that folks understand the VQI data set and its limitations by now. We probably could have spelled it out more explicitly in the literature. I think you just have to read it as an informed reader and sort of decide this has taken over a 13-year period, and so there's going to be some changes.
Dr. Rasmussen, would you like to ask your question?
Well, I think that, thank you. First of all, it's a great review. Congratulations on the paper, and appreciate the forum. I mean, I think, as is commonly the case, we do the best we can with registry-based studies. I think they're important to inform our practice. Occasionally, the FDA will acknowledge them for regulatory measures of regulatory standards, but really, often these registry-based studies are so sort of dirty in the data that the best they can do is inform an RCT or at least a prospective, more controlled trial. And I guess my question is, and this is not an uncommon strategy, is you do a registry-based study like this to inform your application for, federally funded controlled trial. If you could design knowing what you know from this, how would you design a prospective controlled study on this topic? I mean, because that's a common strategy, and frankly, kind of what we, I think, we as vascular surgeons aren't always good at that, at following through, but I'm interested in whether or not you think a controlled study could follow this.
Yeah, I think that's a great point. Whenever I think about how can we do a trial in the peripheral vascular space, you have so many factors you have to control for, and you really want to control, you really want to compare apples to apples. If you take the simplest iteration and say, we're just going to look at superficial femoral artery treatment with stenting, there are so many iterations as it is that you really have to, the calcification length, task classification, the, it's an occlusion or a stenosis, what modality was used, if we even just look at stenting, covered stenting versus bare metal stenting. So I really think people have shied away from doing that in some ways because it's such a Herculean undertaking. That being said, I think looking at things like the optimized medical therapy arms versus versus intervention arms, and as I mentioned before, this ironic trial that came out of Sweden, which I had no idea about, and they really looked at the benefit overall, saying that there were fairly similar benefit between optimized medical therapy and intervention at 2 years, but at 5 years there was no benefit. And so you just sort of have to wonder about how we would structure a randomized control trial. And I think the reason why we don't have one is probably because you have to control so many different variables.
Yeah, I think that the British have been great about sort of adaptive designs. I mean, you guys have sort of led the way in several different topic areas. There are new, whether it's Bayesian methodology or more efficient, pragmatic design, trial designs. I'm not an expert at them, but I'm sort of looking at even the FDA issued guidance on adaptive designs for medical device studies in 2016, and they did that to sort of address the challenges you're mentioning, which is the these conditions in which the number of variables is so great. You need a different type of trial design. It can't be a sort of a black and white old-fashioned RCT. And I guess I'm challenged to think about it, because I think we as surgeons frequently we end our research with a registry-based study and we say, well, the data is not good enough, and then we go back to the OR and we tend to not take that next step, which a lot of our medical colleagues do. They apply for federal funding and they do they use the registry-based study to then inform, because this is a tremendous amount of information, to inform then the next step in trial design or study, and then level of evidence ultimately. So
I think anyway, we have to allow enough time for the other papers. So maybe we'll ask Dr. Wu to give us some final thoughts for this paper before we move on to the next.
Yeah, thanks for having us, and thanks for talking about our paper. I think what our real goal here was to look at the outcomes that are important to patients. So the outcomes being, did your claudication get better? Because it's all about treating claudication is all about the patient's lifestyle and the patient's perception of whether they've improved or not. So, just I heard some of the other discussion about, why did we choose that as the outcome? So the patient, if the patient reports, yeah, I have claudication, then that's a failure of their treatment, right? Because we treated it to make them feel better. And so even if there was no objective like treadmill testing or whatever, like the patient thinks they have claudication, we fail. So I think that was why we chose that as the main outcome. And in terms of not having subgroups, once you start doing subgroup analyses, you lose your power. And we already didn't have power by limiting it to the population that had adequate follow-up. We already got rid of a lot of our power in that. And so we weren't able to do do the subgroup analyses, but you do have the hazard ratios from the multivariate analysis that tell you, the difference between patients who were on the statin and the smokers. And so that gives you an idea of the effect of those things. And then in terms of like a prospective trial, I think it would have to be something pragmatic, something kind of like BEST trial, where you limit the inclusion and exclusion criteria, and in that way you kind of try to create a more homogeneous population. So maybe we would limit it to people who are undergoing their first intervention for claudication, or who haven't been treated for claudication, or like only severe claudicators, or some kind of thing like that, where you manage the population. But it would be impossible, as John said, to standardize, the degree of calcification and all the different interventions that you can do, and et cetera, et cetera. It would be an extremely difficult study to design. And I think you'd face a lot of the same challenges that the BEST trial is facing now. But that's, I think, all I have to say.
Thank you, Dr. Wu. I do think I agree with you about how difficult it can be sometimes for a lot of us to get excited about pragmatic trials, because we're so kind of specific in certain ways. But thank you both, Dr. Bath and Dr. Wu, for being here to discuss your paper. It's very exciting when you get that kind of robust conversation from the authors themselves. We are going to move on to our next paper, which is validation of the global limb anatomic staging system in first-time lower extremity revascularizations. And Dr. McGee is going to get us started.
Thanks, Misty. So, as was mentioned, we're going to be talking about a paper on validating the GLASS anatomic staging system for lower extremity peripheral arterial disease. And as we know, there are several different previous classification schemes for lower extremity PAD that have been proposed, including the Fontaine classification, the Rutherford classification, and the TASC2 classifications. And of these, TASC is really the only one that describes the anatomic extent of disease. But because it has separate systems for suprainguinal, suprapopliteal, and infrapopliteal disease, and there's no clear way to account for disease at multiple different levels, there's been proposed a need for an update to this, and ideally using a system that was more clinically relevant. So that brings us to the goals for the global vascular guidelines, which involve leadership from the European Society for Vascular Surgery, the Society for Vascular Surgery, and the World Federation for Vascular Societies. And there's a lot in this original paper. I'm not going to get into all of it, obviously, but they define this concept of the target artery pathway. And that essentially is quite literally the path that one would take if you were going to revascularize an artery through an endovascular approach. So here's the yellow drawing of where the wire would go if they were going to choose to revascularize the foot through this pathway, either endo or open. But then using that target artery path, they then define a femoral popliteal grade, which it bears some similarity, I would say, to the TASC system. It's not the same, but it has some similarities in terms of 4 different levels and increasing severity. And then in addition, there's an infrapopliteal segment. Again, this is different, but could be thought of as maybe analogous to the TASC system infrapopliteal grade, but with an emphasis on the primary tibial artery that was going to be revascularized. So as opposed to having multiple tibial arteries that are occluded. This focuses on again, that target artery path. And then it takes the 2 grades for the femoral popliteal and the infrapopliteal and combines them into a staging system. And this when I first saw this, it sort of reminded me of Wi-Fi, the way that you combine multiple different scores to get a stage, and it is sort of analogous, like Wi-Fi, to the TNM staging for cancer. And it looks kind of like diagonals here. So then the higher the grade of each of those 2 systems, then the higher your stage would be. And then importantly, they also defined this concept of a plan, that the correct treatment plan for a patient should ideally account for 3 factors. One is the patient's risk, their life expectancy and longevity, risk of any procedure that was going to be planned, the limb staging with Wi-Fi classification. And again, this is specific to chronic limb-threatening ischemia with rest pain or tissue loss. And then the anatomic complexity of revascularization using the glass stage. And then, like I said, the glass stage combines both the fempop and the infrapopliteal grades to create their stage. But this, similar to Wi-Fi, also was proposed without really being clinically validated. And so there is a need to clinically validate this anatomic staging, which brings us to the paper that Callie will present for us.
Okay, so it's a pleasure. I'd like to, let me see. Thank the journal for the incredible opportunity to present. Again, we'll be speaking about the validation, and I'll go through some things very briefly, as Dr. McGee has mentioned them pretty thoroughly, that we're addressing the validation of what was proposed in 2019 by this global guidelines, a joint effort. And just to really narrow it down from the first paper, we're not talking about all of peripheral artery disease. We're really narrowing it down to those with end-stage disease, the chronic limb-threatening ischemia, those with rest pain and tissue loss. And then Dr. McGee mentioned the plan, and really it's addressing the patient, the limb severity, and then what we'll be talking about today is the anatomic features of that limb and what it would take to revascularize it. And so the real goal with glass that I could glean from the 2019 guidelines is that it's to assess the burden within that whole limb, and mapping that target artery pathway from everything from the infrainguinal down, actually beginning at the origin of the SFA. And there's a couple different modifiers and descriptors that are talked about that aren't necessarily in the core of glass, but brought up as future directions.
Sorry, Callie, are you going to share your screen?
Oh, I would love to. Is it not?
No.
Let's try that again then. Are you able to see a screen at this point?
We are.
Yes.
So I apologize, but all of those actually were discussed by Dr. McGee. So we'll start there. Thank you for the update. So yeah, so the real goal, I think, with the global guidelines was to create something that's clinically meaningful in a staging system. And so what was proposed was to have something that also addressed the technical failure prediction based on that anatomic, and then what's called the limb-based patency, or that target artery pathway, and in a clinically relevant way. And so this paper was a single institution retrospective review, again targeting the breast pain and tissue loss. Had 1,180 limbs, and about 50% were open and 50% endovascular. They looked at angiograms and assigned glass classification to those patients or those limbs. And then ultimately at their follow-up, they had standard interval follow-up as best as it could be done in a retrospective review with non-invasives, and their average follow-up was 2.9 years. And so what's important when you're looking at this, I think, is that you can see that based on the glass classification, they were able to identify different severities of clinically distinct patients. So within their demographics, you could see that stage 3 patients tended to be older, had more coronary artery disease, were more likely to have tissue loss, more likely to be ischemic, have a higher grade of ischemia versus infection in a Wi-Fi classification. And so the primary outcomes that the authors looked at, they used a composite outcome as their main primary outcome, and that included restenosis, reintervention, and major amputation. And then as secondary outcomes, they separated these out into individual restenosis, reintervention, and major amputation, and then also included all-cause mortality, amputation-free survival, and technical failure. And they looked at these at 1 and 5 years. And so within their composite outcome, I think that this speaks to a predictive model for clinical staging. You can see that their composite outcome, they did have distinctions between stage 1, stage 2, and stage 3 disease at both 1 and 5 years. And again, that composite outcome being restenosis, reintervention, and amputation. And then I've included here in yellow sort of what would have been predicted based upon the 2019 presentation of glass. And so not far off from actual predicted limb-based patency by the SVS. And then based on the text in the paper, I sort of created this diagram, but you can see breaking down each of those composites when you look at them as secondary outcomes. For stage 2 and stage 3 disease, there was a distinction that was for re-intervention and restenosis, and then a trend towards significance for the amputation. But really, their composite outcome was being driven by re-intervention and restenosis. And then the secondary outcome of mortality, you can see that although not significant, it did follow the same trend of clinical staging. And then addressing the SVS's additional point of initial failure. So they looked at failure to cross a lesion based on these glass classifications. And again, with the predictions based side by side for what the SVS had predicted, there was increasing grades of failure in that initial based upon the stage. And then interestingly, so the SVS mentions pedal disease, but sort of unable to really define that within the glass classification, not included in the initial scoring system. What the authors found was that if you separate out P2 versus P0, which is essentially you have nothing that crosses the arch and crosses the malleolus and forms the pedal arch versus those that have an intact arch. They did find that that composite outcome was higher in those that had P2 disease. And also interestingly, this was the data point that tracked with amputation. So the glass clinical staging of 1, 2, and 3 did not as an individual outcome, but it did for this pedal disease. And that holds up at 5 years as well. And then just looking at sort of distribution, there was a mention at the end of the article, sort of breaking down endovascular versus open, and you can see a trend toward, or not a trend, but a practice pattern of more open interventions for more severe disease. And then really what this was broken down into, for endovascular, about 50% were stented versus angioplasty alone. And then within the open bypass, you can see almost 90% were vein open bypasses. There wasn't quite enough data between different intervention groups to really assess by the staging system within the intervention. But you can see within stage 1 that there were more, let me see if I have this here. Yeah, this is their composite outcome. And endovascular had a higher composite outcome for stage 1 versus bypass, which may, we can maybe leave that for the authors to postulate on, but just interesting to note. And then again, these intervention or the composite outcome results were being driven by the reintervention and restenosis and not by amputation. And so the conclusions really that I took from the paper are that practice patterns, more severe disease is being treated with open surgery. That higher glass classification was associated with this composite outcome, but mainly driven by restenosis and reintervention and not by amputation. And so maybe this composite outcome isn't the perfect marker, and we should be really looking at maybe just reintervention. And that severe pedal disease was really the only predictor for amputation, and really suggestion would be to be able to incorporate that into a glass classification. And so I personally think that GLASS provides a common language that allows us to compare these really complex patients, and that we should be collecting data for all of our CLTI patients so that we can adjust these stages to actually be clinically meaningful to provide data for outcomes. I'll sort of go through these quickly, and maybe that can be similar to TNM staging for cancer that adjusts with how our treatments improve. And then that pedal disease may be a marker for more severe disease. And then I'll just sort of pose these and maybe we can go to the chat, but really what's the goal of GLASS? Is that to provide some clinically meaningful outcome data versus selecting treatments. And then can we integrate that as they had suggested into a plan, including Wi-Fi in the patient? So I'll stop my screen sharing there.
I think you're muted.
Was I muted for the entire presentation?
No. Dr. Doherty is speaking. He's muted.
Yep. Sorry, can you hear me now?
Gotcha.
Okay, yeah, the spacebar trick didn't work. Anyway, I was saying I think I need a classification system for classification systems because this stuff is getting extremely complex. And that's a tremendous amount of work that was done looking at nearly 1,000 patients to come up with these scoring systems. One thing that I didn't understand in either this paper or the original GLASS description is that aortic disease falls into this. Are we only looking at disease below the groin when we're using this system? That's for.
Hi, yes, this is Patrick. I'm the first author on the paper. So yes, the GLASS classification system only has classifies the infrainguinal disease, so does not account for the aortoiliac disease if present.
So no patients who had interventions for aortoiliac disease are included in this data set?
Correct.
Gotcha. Let me see what I can glean from here. It's kind of interesting. I mean, I guess one of the problems with the composite is that you're equating sort of an amputation to a duplex finding of a velocity ratio of 3.5, which are very different outcome events. And I gather that once again, to get the numbers you need to have didn't reach significance because there weren't that many amputations. But that is, I think, also one of the weaknesses of this kind of thing is that those are obviously not clinically similar events, just like gangrene and an ulcer are not necessarily equivalent problems. Dr. Mills had a question regarding the pedal disease, which was the interesting thing. That was the one thing that clearly did correlate with amputation rates. Joe, are you available to explain your question? Looks like you're muted.
The only pedal classification I'm aware of that's been looked at very much is Kawahara from Japan. And we couldn't reach agreement on the committee if we were going to adopt that. So we basically chose 3 scenarios. One where there's at least one good vessel across the ankle and there's a complete arch, and 2, there's a vessel, but the arch isn't incomplete, and 3, there's nothing. And so that's kind of simplistic, but it actually, at least in this paper, panned out. And I think one of the things that's interested me the most about this disease is I trained with John Porter, and basically at the time we were doing bypasses on all these patients, we didn't see this much pedal disease. I mean, it basically had 2 subsets, SFA popliteal disease, and then really bad tibial wipeout. There was almost always a distal perineal or a posterior tib or a DP that you could go to. And when you did that, you got robust first foot circulation. And over the years, especially the last decade, I think it's because of renal failure, but also more diabetes and people living with it longer. But we see a lot of patients that have pretty normal vessels or easily correctable things down to the ankle, and the foot itself is bad. So I think that probably, depending on your practice pattern. So now in Houston at Baylor, I think 25% of our patients are on dialysis. It's a referral issue, but these people have horrible pedal disease, and it has a huge impact on their outcome. But anyway, there's another question about the complexity of this is the following. So Wi-Fi was meant to stage the limb. It's like staging the cancer, TNM, but all glass does is stage the vascular anatomy. So if you're looking for limb salvage outcome, if you had a low stage Wi-Fi patient with a smallish ulcer and you did really complex endovascular therapy and improved the flow enough that you could heal a toe amp or an ulcer, and then that failed, but you offloaded the patient, they were in comprehensive care and their foot stayed healed, that's probably a win from a patient standpoint, right? But so I think that you have to eventually get enough data to integrate all these together, because my bias is that, and there's some data for this, the really high Wi-Fi limb stages do better with bypass if bypass is possible for the patient and if they have a conduit. And I think those are the kind of patients we used to bypass all the time. That's not been totally confirmed, but there's a couple studies now that agree with that. Desert foot would be the worst stage of the, I think Wei Zhu asked that, but that would be that's the kind of patient that we're doing venous arterialization on. They don't have anything in the foot you can bypass to. And when you put wires and catheters down, you can't find anything to recanalize.
And the rationale of the glass is really to find something that's clinically relevant and a little different than just looking at lesion-related interventions. But again, it's complex, and I think Greg McGee was asking, should you be using this in parallel with Wi-Fi and other systems to generate?
So in the global guidelines paper, there's a 3-dimensional figure that Mike Conti helped create that kind of puts together all 3 things. So how long is the patient going to live? How advanced is their limb presentation, and how complicated is the vascular anatomy? And so if you had a patient that was still functional, but towards the end of life and had a lower stage Wi-Fi limb, endo might be the way to go. But if you had a more functional patient with long segment disease, anatomically in a high Wi-Fi stage, and they had a conduit, bypass might be the way to go. So you really can't, I think this whole movement that started with Wi-Fi and ended up with the global guidelines was in response to people just treating angiograms. Because we've all done this for a long time, right? You can't just look at the angiogram and tell me what the patient needs. You've got to see the patient. You've got to look at their other risk factors. You got to see if there's conduit available. And you got to think about what kind of procedures will this patient tolerate. And it's why I think the decision making is always complex. If you only know one method, if all you can do is endo, then you're going to endo everything. And that's what unfortunately happens in some places where I think we all see these patients, right, that have had multiple interventions, and sometimes their bypass target is ruined. And that's really a shame. So the idea behind this was to come up with some system that would force you to think about more than the angiogram.
So Patrick, what's our what's our take-home message from this, one of the first, I think, validation series on the glass?
I think it's an interesting new classification system. Obviously, there's been many that have been proposed, and I would say a lot of them haven't taken a good foothold. So hopefully this one going forward, we can use to communicate with each other to help counsel patients on what their risk of reintervention amputation is based on their stage of disease. So hopefully, potentially, this will be something that's used going forward.
I feel like Dr. Doherty is frozen all of a sudden, so I'm going to kind of jump in here. It took me a minute to decide if he was thinking or if he was frozen. So, but thank you, everybody. There's a lot of great discussion. I know Dr. Sampson wants to know if we're fitting in atherectomy and money, but I think that's a question that's a little provocative. So I think we'll leave that one for next time. We appreciate everybody being here. I think we had some really great discussion about the various papers. Our next event will be in June. We do these the second week of June, and we'll be sending out information on social media. Thank you to the authors and the special guests. Just a great conversation. Have a wonderful night.
Thanks, Misty.
Thanks, Misty.
Great job.
Thanks, Misty.
Thanks all for participating.
Thanks, Misty and Paul. Very good.
Good night. Pleasure. Thanks again, Misty. Have a great evening.
Absolutely. I think it went really well. Lots of great conversation. So, so wonderful.
Thanks for being here, Peter.
Like 85, 90 people. That's amazing.
Yeah,
Really
Just
good.
they were
keeps getting
really,
bigger and
really
bigger.
good articles, and it was nice for people to join us.
Yeah, very good. And these were good papers.
All right. See you guys later.
All right.
Thanks all. Bye-bye.